Are you there?
Yeah, excuse me, everyone. May I go live?
Yeah, please.
Yeah. 5, 4, 3, 2, 1. You are live now. पूजा मैम कर दीजिए, है ना?
Thank you, Rahul. Good evening, all. Myself, Dr. Priya and Sam, medical advisor of Lupin team and the Lupin metabolics team, would like to welcome you all to a very enlightening panel discussion today. The topic today that we will be discussing on is managing hyperglycemia in COVID-19 patients, where recently, that is on 26th August 2020, Ministry of Health and Family Welfare Guidelines had released this, emphasizing on the use of vildagliptin and metformin combination in these patients, as well as the use of conventional insulin. To further help us understand about these guidelines, we have with us 5 renowned and well-known speakers, and they are Dr. Vagesh Iyer, Dr. Das, Dr. Sriram Mahadevan, Dr. Sarita Bajaj, and Dr. Altamash Sheikh.
Hello.
Before starting the session, I would like to inform the audience to please mute their mics and type in your questions in the chat box that will be taken up after the session. Is the slide visible?
Yes.
Yes.
Okay. So as mentioned in my introduction, the topic is where we are managing hyperglycemia in COVID-19 patients in diabetes. And this is a guideline that has been released by Ministry of Health and Family Welfare Guidelines. As per the IDF 2019, it is seen that India is in the second rank of where the number of people with diabetes is increased, where first is China. In this present scenario, we have seen that diabetes is seen as a risk factor for hospitalization and mortality of COVID-19 infection. And diabetes has been seen as a comorbidity in 22% of 32 non-survivors in a study of 52 intensive care patients. There was another study that was conducted where 173 patients were affected with the disease, and of which 16.2% of patients had diabetes. And from that, 140 hospitalized patients were seen to have 12, of which 12% had diabetes. People with diabetes are a higher risk group for severe disease. In June 16, 2020, doctors have added that diabetes to the list of COVID-triggered conditions. If the patient is diabetic, there are high chances that the patient can be affected with COVID-19. This was again another study that the experts have mentioned that COVID-19 may trigger new onset of diabetes. Now, there are different evidences that also show where COVID-19 in diabetes is limited at present, where they have seen that diabetes was present in 42.3% of 26 fatalities due to COVID-19. Diabetes was not a risk factor for severe disease course. There was a number of comorbid conditions that shown that diabetes is a significant predictor of mortality. And also in Chinese Center for Disease Control and Prevention showed that there was a report of 72,314 cases of COVID-19 patients with type 2 diabetes. If you see in this table, it is seen that after cardiovascular disease, hypertension, we can see here diabetes patients are more affected, or the diabetes is the most affected comorbid condition where after it comes up, where it comes before COVID, cardiovascular disease and hypertension. Morbidity and mortality varies from 14 to 32% in different studies. 72% of COVID-19 patients were seen that were admitted in ICU. Diabetic patients had a hazard ratio of 2.34, and significant correlation was seen in severe COVID-19 and diabetes group. The prevalence is also seen that it is more with diabetic subjects. So what are the reasons for hyperglycemia in COVID-19 patients? It can be steroid-induced hyperglycemia or stress-induced hyperglycemia. Steroid-induced, as we all know, that high dose of steroids can increase the blood sugar level, thereby causing diabetes mellitus. In stress-induced hyperglycemia, you can see that due to the stress of illness, there is an elevation of blood glucose seen, but this can be resolved spontaneously. In this is where the guideline starts, where the Ministry of Health and Family Welfare have issued a table where they have shown how to screen hyperglycemia in every patient hospitalized with COVID-19 at the time of admission and on starting steroids. So here you can see that all newly admitted patients have to be evaluated for diabetes or hyperglycemia. Check the continuous blood glucose, one value pre-meal and one value 2 hours after the major meal, that is a post-meal. If the pre-meal is less than 140 milligram per deciliter and post-meal is less than 180 milligram per deciliter, advise healthy diet. There is no need of further monitoring and send the fasting plasma glucose and HbA1c to the lab next day. But if the pre-meal is more than or equal to 140 and post-meal is more than or equal to 180, continuous blood glucose testing over next 24 hours needs to be seen, that is before breakfast, before lunch, before dinner, after dinner, and the fasting and HbA1c should be sent to the lab next day. If the modest elevation of one or more values is pre-meal 140 to 150 or post-meal 180 to 200, diabetic diet need to be advised, after which the blood glucose values need to be monitored and the oral anti-diabetic drug or insulin therapy need to be titrated according to the values. Similarly, if there is a significant elevation of more than or two, that is pre-meal more than or equal to 150 and post-meal more than or equal to 200, again diabetic diet need to be advised. Oral anti-diabetic drug need to be initiated, which we will be mentioning in the upcoming slides, and insulin therapy need to be initiated and titrated, which will be discussed in the upcoming slides. If any value is more than or equal to 200 with osmotic symptoms, send the fasting and HbA1c the next day to the lab. And similarly, of how we discussed with pre-meal and post-meal more than or equal to 150 and 200, the same advice is need to be considered. So the Ministry of Health and Family Welfare guidelines mention that use oral anti-diabetic drug if the blood glucose levels are controlled, that is pre-meal is less than 140 and post-meal is less than 180. If the patient is conscious, oriented and has good oral acceptance, if the COVID symptoms are mild and the kidney function and liver function tests are normal. Now to initiate oral anti-diabetic drug, especially newly detected diabetes at the time of admission, that is, if pre-meal is 150 to 180 or post-meal is 200 to 250, consult the endocrinologist or consulting physician at the earliest to start OAD. But if there is a delay in consultation, the guideline mentions that initiate on tap metformin, either immediate or sustained release, 500 milligram twice daily, and a gliptin, that is vildagliptin in this case, which is 50 milligram twice daily. Now, this particular study is focusing on where this article was focusing on the pharmacological possibility of DPP4 inhibition or activity by using vildagliptin, which mentioned that this represents a valid weapon to block the host CD26 receptor, thereby disabling SARS-CoV-2 way to enter the T cells. Now, once we have completed a talk discussing about oral anti-diabetic drug, we have the use of insulin, conventional insulin. But before that, we all know that in COVID-19 patients, glucocorticoids steroids need to be administered. What are the different types of glucocorticoids? We have the short-acting hydrocortisone, intermediate-acting prednisolone, long-acting dexamethasone. And the commonly used glucocorticoids are the methylprednisolone and dexamethasone. Here we can see that high dose of long-acting steroids will cause hyperglycemic effect throughout the day. Thereby, you will require high insulin doses. So if the patient is on high-dose intermediate-acting steroid, for example, if the steroid was given at 9 a.m., the peak hyperglycemic effect is seen to be between 12 p.m. to 8 p.m. Accordingly, the patient will require a higher dose of insulin before lunch. So what is the best option? The guideline mentions that the pharmacokinetics of insulin NPH mimics the steroids. So in the previous condition, we can say that insulin NPH may be useful since pharmacokinetics of NPH mimics the effect of steroid on blood glucose level. So if we can administer NPH insulin at before breakfast or at 9 a.m. in such a scenario. Next is about how we can initiate basal-bolus regimen for patients newly detected with diabetes. That is admission pre-meal if blood glucose is more than or equal to 180 and post-meal blood glucose is more than or equal to 250. The total daily dose should be equal to 0.4 units per kg per day. And the condition says that if the patient's age is more than 65 years, if he's having nephropathy or liver disease, use 0.2 units per kilogram per day. The total daily dose can be divided equally into 4 doses, that is 25% each, where 3 doses are of bolus insulin, where regular insulin is being used 30 minutes before breakfast, before lunch, and before dinner. And 1 dose for basal insulin is being recommended, that is injection NPH insulin at bedtime or 2 hours after dinner. So in short, they are mentioning that if the blood glucose pre-meal value is more than or equal to 180 and post-meal value is more than or equal to 250, despite on starting with if the patient is on OAD, please start basal-bolus insulin regimen. Now, from insulin infusion, how can you switch to basal-bolus insulin regimen? Here again, you need to calculate the total daily dose based on the insulin infusion requirement for the last 24 hours, where it is mentioned that the total daily dose is equal to 80% of the total daily insulin requirement on IV infusion in the last 24 hours. So once you have the dose, calculate the doses of bolus insulin and basal insulin like how we had mentioned before. For example, we have a 54-year-old patient with IV insulin and his blood glucose level has been controlled for last 24 hours. His oral acceptance is good and his vitals are stable. At 11 a.m., his blood glucose level was seen to be 132 milligram per deciliter, and the team decided to switch the patient to basal-bolus regimen. The dose has been calculated. The plan is to start injection regular insulin, 6 units subcutaneously before breakfast, 6 units before lunch, and 6 units before dinner. And NPH insulin is given as 6 units subcutaneously at bedtime, or it can be given 2 hours after dinner. So at 11 a.m., you do not stop the insulin infusion. You continue till lunch. At 12:30 p.m., while the insulin infusion is going on, you can give injection regular insulin 6 units subcutaneously. Let the patient have his lunch at 1 p.m., after which the insulin infusion will be continued as per scale and it will be stopped 1 hour later, that is at 1:30 p.m., which is after the overlap. Now, if the patient is on Braille's tube feeds, the feed should be divided into 3 major and 3 minor feeds, depending on the calories or the quantity of the feed. So if the major feed is 300 ml each and minor feed is 150 ml each, timing of the major feed will be 9 a.m., 1:30 p.m. and 7 p.m. And the minor feed will be 11 a.m., 4:30 p.m. and 10 p.m. So the basal-bolus insulin regimen would be preferred in these kind of patients. Bolus insulin, that is regular insulin, should be given 30 minutes before each major feed, and basal insulin, that is NPH, should be given at 10 p.m. along with the last minor feed. The capillary blood glucose should be monitored before and after 2 hours of each major feed. Now, the clinical guidance on anti-hyperglycemic treatment initiation and titration in patients with COVID-19 and diabetes has been released as per 4 scenarios. The 4 scenarios are: if the patient is detected to have hyperglycemia at admission or on starting steroids. The second scenario is whether the patient is on OAD at the time of admission or during follow-up. If the patient is on basal-bolus regimen at admission or during follow-up, and if the patient is nil per oral. Coming to the first scenario, where the patient is detected to have hyperglycemia at admission or on starting steroids. If the pre-meal is less than 140 and post-meal is less than 180, as we had discussed previously in the first slide, we follow healthy diet and there's no further monitoring required. If the pre-meal is more than or equal to 140 and post-meal is more than or equal to 180, you need to monitor the blood glucose level and advise diabetic diet. Pre-meal between 150 and 180 and post-meal is between 200 and 250. Start tablet metformin 500 milligram twice daily and linagliptin or vildagliptin 50 milligram BD. Pre-meal if more than or equal to 180 or post-meal if more than or equal to 250, start on basal-bolus insulin. If pre-meal is more than or equal to 300 or post-meal is more than or equal to 400, start on IV insulin infusion. And if the patient is on diabetic ketoacidosis, start on IV insulin infusion. The next scenario, if the patient is on oral anti-diabetic drug at the time of admission or during follow-up. If the pre-meal is less than 140 and post-meal is less than 180, continue existing OAD. If it is more than or equal to 140 and more than or equal to 150, you can upgrade the existing OAD. If the pre-meal is more than or equal to 180 and post-meal is more than or equal to 250, start on basal-bolus insulin. If the fasting plasma glucose is, if you're looking only at the fasting plasma glucose and it is more than or equal to 140 milligram per deciliter, add basal insulin at the bedtime along with your existing oral anti-diabetic drug. If the pre-meal is more than or equal to 300 and post-meal is more than or equal to 400, start on IV insulin infusion. DKA, as I mentioned before, start on IV insulin infusion protocol. If the patient is on basal-bolus regimen at the time of admission or during follow-up, you continue the existing basal-bolus regimen if the pre-meal is less than 140 and post-meal is less than 180, and if the patient has no episodes of hypoglycemia. If the pre-meal is more than or equal to 140 and post-meal more than or equal to 180, you can optimize the insulin doses. And if the pre-meal is more than or equal to 300 and post-meal is more than or equal to 400, you can start on IV insulin infusion. DKA is the same as before. If the patient is nil per oral and you check the blood glucose level 2 hourly, if 2 hourly values are more than or equal to 180, start IV insulin infusion. Now, on the month of September 2020, there was a study that was conducted to see how is the basal-bolus insulin regimen for hospitalized patients, and it was concluded that there are uncontrolled hyperglycemia with poor clinical outcomes in hospitalized patients who are affected with COVID-19. And the review they had conducted provided a guidance on the use of basal-bolus insulin regimen for managing hyperglycemia in hospitalized patients. There were also various case scenarios that also they have shown how to achieve the blood glucose control through adjustment in dose of prandial and basal insulin, and how to correct the insulin dose and change in timing, and also the content of major and minor meals. The guidance can be used for patients who are admitted for indications other than COVID-19 and for those in ambulatory care. So what are the points that we need to remember? That is, insulin doses can be titrated proactively and not reactively based on the previous day's blood glucose value. The dose of bolus insulin for each major meal is titrated such that pre-meal to post-meal blood glucose increment remains around 30 to 50 milligram per deciliter. Basal dose is adjusted based on the fasting plasma glucose. And for most patients on basal-bolus insulin regimen or for inpatient hyperglycemia management, in general, if the pre-meal is less than 140 and post-meal is less than 180, can be targeted. In selected individuals, that if the target level is less than 120 and less than 160, the basal-bolus insulin regimen can be considered, provided they can be achieved without causing undue hypoglycemia. So in short, this is how the Ministry of Health and Family Welfare have released the guidelines on the use of vildagliptin and metformin as OAD for COVID-19 patients, and the use of regular insulin and NPH insulin for the same group of patients. So now I would like to understand from the panel, starting with Dr. Sarita, on how can we implement this in clinical practice? What is your suggestion and opinion about this guideline that they have released?
So what you are planning to show is, this is a slide deck that has been prepared, and this is based only on the Ministry of Health and Family Welfare. That is it. We are not going beyond this at all. Because there are a lot of things that we can incorporate in this deck to make it more complete. I think the other members would agree to that.
Yeah.
And then isn't it? Because whatever you are going to show should talk about diabetes in its entirety. Of course, we are talking in relation to COVID-19. There's no doubt about that. So, of course, there are some little corrections within the slides per se, but then we can make additions as well. For example, I think it would be better to use the terminology of blood glucose rather than blood sugar. And all patients who are admitted in the hospital are evaluated for dysglycemia. That includes COVID-19 as well. And see, whatever slides you are showing, if there is more data in the context of COVID-19 in a tabulated fashion, that would look much better. Because you've just shown a couple of studies in China, very small data you have shown. You can tabulate all of that and make it whole. Yes, there is, where you want to focus on vildagliptin. Overall, you're talking of gliptins per se, because in one slide, remember, it mentioned just linagliptin. Is that, are they recommending only linagliptin, or should it be gliptins as a whole? Yes, I know there is data.
Gliptins as a whole, yeah.
Isn't it? So that needs to be corrected as well. And see, we have several studies on DPP-4 inhibitors as a whole, small. Some of them have shown no harm, no benefit. Like from China, there are 2 studies. France, there are 2 studies. Italy, there's a study. And the largest one was from Korea, in which there are about 263 patients out of 332. And they showed it was significantly better. So if you incorporate studies focusing on gliptins as a whole, and I don't think we need to mention one particular gliptin at that point in time. And you said somewhere about immediate release metformin. I thought immediate release metformin was more difficult to get hold of than sustained release metformin any day. And you
yeah, that is what the guideline has mentioned. The Ministry of Health and Family Welfare, they have mentioned it as either immediate or extended release of.
Yeah, anything is fine.
Yeah, anything is fine, but I always thought immediate release was more difficult to get hold of, and immediate release is better for if you have a postprandial, specific postprandial hyperglycemia, the effect is better. And when you show those 2, I think, parrots in that slide, which steroid are you talking about? That is not clear at all. And then you haven't mentioned anything about the duration of action of methylprednisolone. In that slide, which you're talking of steroids, that is not mentioned. And I think you can use any terminology like BDN. I don't think that's standard. Is BDN or before lunch. And of course, I think one should categorically mention that we do not use the sliding scale. You've written that at some point in time, but I think we should clearly mention that that is not done. And we have a term like NODAT, that is new onset diabetes post-transplant. So here we can talk of NODAC 19, that is new onset diabetes after COVID-19. And I think, isn't it? I think this is the era of terminology, of coming up with new terms. So maybe you can, of course, you've written, and then there should be an explanation behind this. And it's categorically mentioned that the comorbidity is associated. Of course, if diabetes is well controlled, then the prognosis is much better. Poorly controlled prognosis, with poorly controlled diabetes, the prognosis is worse in association. And I think those also need to be categorically mentioned. Obesity is a major comorbidity. Obesity is a major comorbid, apart from hypertension, apart from dyslipidemia, apart from malignancy. And I think there is data on even hypothyroidism. There's data on hypothyroidism also. Then the ACE inhibitors, especially when you want to focus on a particular molecule like gliptin, you need to explain. It's anti-fibrotic, it is immunomodulatory. So there are a lot of benefits. I think those need to be brought out apart from the data in relation to and then the individual oral you are saying that if the blood glucose is within a particular range, then you can continue the oral agents. Okay, but each specific agent we need to talk about, whether it's metformin, whether it's sulfonylurea, of course DPP4 will have to be discussed. What about SGLT2 inhibitors? What about what about thiazolidines? Thio is the only one we might be using. Is there any gliptin, for example, saxagliptin? Do we have data which says perhaps saxagliptin should not be used? Then glucagon, GLP-1 analogs, what about them? So everything is, we have data on all these agents. Yes, metformin, yes, we can continue. Are there any specific, like if you have to look at the liver function, you have to look at the renal functions, if the patient has AKI. So all these riders should be mentioned. Sulfonylurea is preferably avoided, glitazones preferably avoided, SGLT2 inhibitors preferably avoided. Even though there is one DARE study which is going on specifically with dapagliflozin, and they are looking into this, what are the benefits in patients with respiratory failure and dapagliflozin. So as of now, we would not use SGLT2 inhibitors. So individual oral anti-diabetic agents must be discussed, and those agents which are being given for COVID. And one very important agent is hydroxychloroquine. But hydroxychloroquine also impacts blood glucose. What happens to the QT interval? We're giving azithromycin. So there are drugs which are also impacting the QT interval. So hydroxychloroquine specifically should be discussed. And then diabetes and COVID-19 sequelae. Though this pandemic perhaps hadn't lasted long enough to tell us what will happen later. But yes, whatever time, 9 months have gone by, what are the results of post-COVID sequelae, the relevance of telemedicine post-discharge. So I think there are a lot of things that we can also incorporate in addition to whatever you have presented.
Thank you, ma'am. Thank you for your. Vagesh sir, next to you, sir. Please share your valuable suggestions.
I think this has been prepared mainly to keep the cost effectiveness, because it is applicable across the hospitals across India. So that's been done a good job. At least in a short time, we are able to come out with one of the guidelines. So one important rider you can put that. See, most of the time when they say that if the sugars are above 180 and all, you need to send HbA1c next day morning fasting. Fine. So for example, patient has come at 10 o'clock. We need not wait till next day morning to send a HbA1c. It can be sent anytime because it doesn't require a fasting. Because what happens is there are two situations when you see a patient with a hyperglycemia. He can be a known diabetic or maybe a stress hyperglycemia. Those things are differentiated by doing a HbA1c, and the impact is huge. If it is a diabetic, we'll be very proactive in managing his glycemia. When it comes to the stress hyperglycemia, most of the time, to some extent, there will be a relaxation from the point of physician. Okay, he's not diabetic. We'll see that next glucose we'll check. Then he may go up. So that's why most studies have found that patient with stress hyperglycemia, they do fare much badly compared to patients who have got a established type 2 diabetes, because there is some amount of inertia from the point of physician. So that can be just put as a rider. Fine. This is kept in because anytime you send, then they demand the report immediately. Many times this may not be possible in the government setup or a setup where the resources are very limited. So that's why they are put, but HbA1c can be sent at any time. Then the second thing, what I was telling, the NPH role comes mainly when you are using the intermediate acting glucocorticoid, that's a prednisolone. Because what happens, we'll be giving a more maximum dosage morning to less in the afternoon and evening. So morning dosage is the only thing which is given. But in COVID, what happens if patient is on the dexamethasone all sugar values will be on the higher side. Uniformly, it's on the higher side. That time, this NPH doesn't hold good. It is like typical our basal-bolus regime with targeting each pre-meal, post-meal, and fasting. It comes only on the prednisolone regime. The NPH does very well. That can be for milder cases we can give. One more thing about the insulin regime of IV infusion protocol changing to the subcutaneous. What has been suggested is we have to take a total of 24 hours. That time will be over calculating the doses. Because what happens initially when person comes with a higher sugar, he requires a higher insulin infusion. But within 6 to 8 hours, in majority of the patients who are insulin sensitive or a newly detected one, their requirement comes down. Generally, what we do is last 6 to 8 hours when the sugar is well controlled between 150 to 200 or 140 to 180, take that 6 hours, what is the requirement, then you convert into 24 hours, then you can give that 80% of that. That is the one. Otherwise, 24, they end up receiving much more insulin than what is required because glucose levels are at the higher side. I didn't understand why they mentioned vildagliptin at the beginning and linagliptin in the end. So initially when vildagliptin was flashed, I thought that probably it has become a generic. It's the most cost-effective with the longest usage record. Probably they have recorded. But the moment the linagliptin came, that argument doesn't hold good. But anyway, all gliptins has to be are good except the saxagliptin because CYP3A interaction is with saxagliptin. That's why we are a bit careful using in the critical situation. And all the points what Madam has told are excellent, needs to be incorporated. Fine. Rider on the each molecule we need to put it and we have to incorporate. Yes, ma'am.
Madam, want to add something?
Just
Yes,
one thing. What about the point of care A1C? I mean, wherever it
no,
can
ma'am.
be.
No, ma'am. They are quite erroneous. Quite erroneous. In fact, this first time this HbA1c point of care HbA1c I experienced when I went for a US Endo conference in 2008. That time that machine was made available in the US. So it showed 6.1. Suddenly I came back and tested in our lab. It came to 5.2 because every year I was doing. Subsequently in India, it was made available 3 years back as one pilot project. We took it. So the errors are on the higher side because in an established lab only we are unable to standardize the HbA1c with the point of care. Probably we are little far away from the practicality. Maybe
so
another few years it should be possible.
Okay. Thank you.
Dr. Sriram Madhavan, what is your experience about COVID and diabetes? Something that you would want to share about what happened with you in the last 7 months?
Though I am in a medical college hospital, our medicine department, frankly, primarily takes care. We are only referred the sicker and difficult to control diabetes. The routine ones who are on OHAs and other things, 90% of the time they manage very well. A couple of points, if I have to, all these points are already mentioned. Especially, Madam nicely coined the term the NODAC. That we have seen at least 4 or 5 times in the last month itself. So that's I mean, maybe they were on the verge. These people are not tested at all. We don't know their HbA1cs were somewhere around 6.5 range. You can call it. So I presume that they were on their verge of becoming diabetic. These steroids and other stress just pushed them to the other side, and they required to the level that they required high dose of insulin. One close friend of mine who's one of the other medicine department professor, he was sharing. We had a Zoom meeting a few weeks back where he was mentioning that these stress hyperglycemia sometimes can be so bad. The insulin requirements are very high for 4 days, and it will crash. The moment they recover from COVID, they are on the point of discharge after the 10th day or so. The insulin requirement goes. So he was asking us what else we can do, what are the predictors for such a thing and all. That day I couldn't answer many things, but I said only monitoring can be done. I'm not too sure. The point on NPH and other things are well taken, and just an extension of that point is we had few patients, especially the so-called VIP ward in our hospital, where the so-called affording people were already on either the degludec, the pre-mixed, those kind of preparations, aspart degludec combination, IDEG. So those people, you should not. What I learned in a hard way, not only for Corona and the previously also, I'm sure all of us know, but it can be told to the practitioners is, don't start for the first time. It takes more than 4-5 days for it to stabilize and control the sugar. That way, I am very happy that regular insulin and NPH are being discussed again in the context of corona. Newer insulins are sometimes, you have to burn your finger. It won't come under control, and suddenly after the 5th day, everything will go down when you would have given. And many other points which were in many slides. Actually, these are all basic internal medicine points in any residency program, in any place. You will be taught all this very well. It's somebody who is a good medical general physician will take care of many of the points which are mentioned. Two more points to add to whatever Madam and Vagish has already mentioned is this HCQ and mention about the cardiac thing and all. Teneligliptin already had a controversy. So I was always wondering, you mix HCQ in these patients and Teneli and that to a 20 milligram BD and all, many people are taking in Chennai also. So maybe we have to be cautious in that respect. And one more interesting drug interaction was pointed out. Remdesivir, which is also even now used, even though the NEJM paper a couple of weeks back is saying that it's not that great in preventing mortality. But the dexamethasone and methylprednisolone are actually having a different kind of effect on dexamethasone, on remdesivir's bioavailability. You use dexamethasone, you might have to be on a higher dose of remdesivir, or the other way. I think you can clarify that there is a definite interaction between the kind of steroid used and remdesivir. We have to be aware of that. In our hospital, all physicians use methylprednisolone as the standard thing. In many hospitals outside, I know they use dexamethasone. So you have to know when you are using remdesivir. And one more point regarding the point of care thing. With one of our medicine PGs last year, we did a small work on comparing HbA1c from the lab versus one point of care HbA1c. It was presented in our ESICON also, I think last year, if I'm not mistaken. Though we have not published it still, the correlation was very good. The thing was, it depends on how you use it. You can't probably use it for, as Vagish pointed out, for diagnosis, but for monitoring in the same patient, it's slightly laborious. I'm sure you might have seen those things. You have to take it in a capillary tube and you have to wait for some time, and it takes 2.5-3 minutes for thing to be done. So I think there is some promising thing there in a rural setting where you can't take samples and bring and get back. Doing a POC HbA1c is sometimes useful, is what I felt. This is my small personal experience, not in a large scale. That's just a point to add. Thank you.
Thank you.
Yeah, what about GAD antibodies, like in that type 1 diabetes? What you said, are you talking of type 2 new onset or type 1? Because type 1 is also known. Shriram?
Yeah, I have not. I'm sorry, madam. Type 1 I have not seen, but DKA getting precipitated in a couple of patients, and we have been one of the team members in managing those patients. At first, I think is expected. It's a sick patient who is on steroids and already concomitant sepsis. Those other things were there. They were not type 1. But type 1 patients entering corona, we had a few of them, and usual management. I don't think they were all very young people, so they recovered very fast. They more of fear which made them got admitted. Otherwise, they could have been even managed at home, probably.
No, but there is definite, there are reports of new onset type 1 diabetes because of beta cell destruction. But that is reported in persons who already have altered immunity. So then, of course, if the antibodies are done, then it will be a strong indicator. I think that's very important. So do they have antibodies pre-existing? So that is also reported. And though in children, it's supposed to be a very mild disease. But since we are seeing type 2 diabetes in children, especially obese children, so I think some of them are also landing up in the ICUs. So there are reports of children landing up in the ICUs as well. So obese children, type 2, etc. So all these things, so like what Vagish said, is the crux of the matter. To decide, like the A1C will differentiate between stress hyperglycemia and a person who's not aware of diabetes. Yeah.
It's yet a new disease, ma'am. We agree with you. We don't still know why a 25-year-old with COVID-19 succumbs, and we do not know yet why a 100-year-old after 25 days of ventilator also comes out.
Yeah.
And in the first half of this 2020, there were case reports about DK precipitated and then patients getting diagnosed with GAD and isolated antibodies positive, and then these are reported in the literature, ma'am. We completely agree with you. So, Dr. Sambit, what has been your endeavor at your center? How was your experience different from the rest of the speakers that they have told? Did you feel that the gliptin helped you? Because there is one study with sitagliptin also which came recently, which talked about the power of how that particular molecule also helped in that particular study. So I think we saw Vilda, we saw Lena, there have been others also. And also we would all like to know from you, Dr. Sambit, once the patient is discharged, what would you do, or when would you restart the patient on overchains? So two small questions for you.
Yeah. So I think definitely the DP4 inhibitor has been good, especially for those patients who are stable, who are taking orally, and who have the glycemia which is not that high. We can start with metformin and DP4. And as Pia has mentioned, only specifically on vildagliptin, I have gone through that document actually that has written vildagliptin, sitagliptin, linagliptin, and teneligliptin. They have not mentioned about saxagliptin, as Vagish was telling. Regarding the document, I think that's a very good document, as Vagish sir has told, that would be helpful for the common physicians. But I have certain points to add to that. One is that SMBG monitoring, that is self-monitoring, that's the glucometer monitoring in the ward. That has been actually, they've asked for 7-point profile. And my clinical experience, as Altamas was asking, both in corporate hospital and also in medical college, though few I have seen the COVID patient, the sisters rarely goes into that room actually. So asking for 7-point profile would be too much. At least a 3-point profile is good. And if the patient is in ICU, then obviously 2 hourly blood glucose monitoring is a good thing. And that's one point. And second point is that the document doesn't mention about hypoglycemia. That's one of the biggest challenge in the both in the ICU and the ward. If you are making a cascading slide from this, you can actually add, even if it has not been mentioned, you can ask a simple protocol about managing hypoglycemia and what the physician or the doctor present there should do in hypoglycemia. I think these are two very important points. And as other panel members have told, that at least we have brought back the regular and the NPH insulin. Again, in my practical point, I have seen in those patients in the COVID ward, the food cart comes very late actually. Like the sister has to distribute. It's not the FNB which gives the food to each of the rooms or into the ward. So it takes a long time. In that place, actually, if possible, if the patient can afford, I think the faster acting insulin is a better option. And NPH slightly differ that the peak happens at around 8 to 10 hours, so it's good for prednisolone. But whatever, even if we are giving prednisolone, I think we need to add a bolus. We cannot just rely on the NPH peak to cover that. So I think that's pretty simplistic, which has been mentioned in that document. I think a complete basal bolus is the answer to that. So these are the few points which I just wanted to make.
Right. I think, yeah, Dr. Priya,
and
yes.
You have asked about discharge.
Yeah. Before I come to you, Sambit, we'll take Madam as a question. Yes, Madam.
Sure.
Yeah, this was regarding, see, the standard regime insulin treatment is basal bolus, isn't it? So I think that will hold good for all patients. The only thing is you want, like you're saying, you want to reduce the exposure of the healthcare worker. So you want to reduce the number of blood tests, the CGMS. Why not CGMS? I think that would be ideal, isn't it? So you want to, so the healthcare workers need to be protected as well. The many more insulin doses, the many more injections. Of course, ideally the patient is injecting, but if the patient is not able to, not conscious, then on ventilator, then it will have to be the paramedics. So how do you reduce the exposure of the healthcare workers? So we have to consider that as well.
7 to 8 point profile is too much actually.
Too much. You can do what you
How
can
much?
do.
How do you advise?
Pre 1 day, post 1 day, something like that. Pre and post, perhaps 2, 3, up to 3. That should be doable.
Yeah, up to 3 is doable.
Yeah.
Yes, Dr. Sambit, the post-discharge you were saying, how would you rate these patients?
Yeah, post-discharge, if the patient is actually stable and he has been taking food correctly and he is already on an OAD and there is no hepatic or renal complication out of that, then I think we can leave the patient with the OAD, whatever he is taking. Maybe SGLT2, we may defer for some time if the patient is not really good. But otherwise, we can continue with the OAD. And if the patient is on insulin, the blood glucose is well controlled. Before that also, the HbA1c has been good, we can continue with that. But what happens is that the pulmonologist and the physician in the COVID ward, they give steroid for the 10 more days after the discharge. So in that sense, I think if the sugars are not in control, the same basal bolus we can continue and leave the patient as such.
Right. Thanks, Dr. Sambit. So we have also seen one more category of patients here. I want to know really from everybody else over here. After discharge of COVID, for those patients who were not, who had only mild COVID, who did not have hypoxia, did not require steroid, after 2-3 weeks of that, the sugars suddenly start going without the exposure of steroids, and the sugars are 300, 400 odd. So is this been also seen, and how should we then manage? Because the patient is healthy, patient is not having any kind of symptoms. Is this a post-COVID hyperglycemia? Is there a new entity that we are seeing even without the patient being on steroid? And then do we really start only on insulin, or we manage with other drugs? One by one, anybody could say, any order. Post-COVID hyperglycemia.
Post-COVID diabetes, we are seeing, and first of all, any patient who is coming with, I think all of us have the same experience. Many patients who are coming with new onset diabetes with severe hypoglycemia.
So we are talking about already a known diabetes patient gets COVID, who's mild, but after the COVID is done, the 14 days, then the sugars start hitting high.
Okay.
Known diabetes, yeah.
I think in that sense, we can start with insulin and correct it.
Okay.
Maybe a basal-bolus or a premix.
Is it possible that during, like the diet and exercise are crucial? So in the hospital, they're not eating enough, they're puking, they're not, like maybe it's just now after it's all over, they're maybe in a celebrating mode, and then they're over. I mean, that could be one aspect. Of course, the exercise part we're not looking into. So they're not exercising in the hospital, but there's a lot of stress there. Here also, they're out of the COVID, but they're not able to exercise. So you're talking of a known diabetic, isn't it?
Known diabetic, yeah. Yes.
Okay, so did they continue their medication? We have to be sure about compliance as well, because at that point in time, the blood glucose levels you are saying were normal, and all of a sudden they start shooting up. Earlier, the patient was on at least maybe 2 or 3 oral anti-diabetic agents. At the time of discharge, definitely no sulfonylurea, only metformin, maybe a DPP-4 inhibitor. So I think there's just too much going on. So the answer is number 1, monitoring. And then taking the blood glucose, of course, if the patient is not, the ketones are not there, I would still go with I would add a sulfonylurea rather than go to insulin, especially if the patient has not been on a steroid. I think I would add an SU and see what happens.
I think I agree with the ma'am, because what happens is COVID, I think many physicians see the patient when they are admitted for 10 to 14 days. And the initial medication may not get reflected when the patient gets discharged. It will be totally to the comfort of the physician who is discharging. The patient will be going on that medication. All probability the sulfonylurea gets missed, because always the hypo is kept at the quite concerned category. So after 2 to 3 weeks, you know how it jumps once you stop the SU in a diabetic patient. That may be the reason. I think it's quite apt, ma'am, what you told.
Right.
Thank you, sirs. Thank you, Altamai sir, also for initiating the process of asking the questions. Altamai sir, for you, there is a question that has come. saying that what are the factors in terms of patient care are likely to mitigate the enhanced risk of mortality?
Well, so there are quite a few factors. First of all, depending on the case fatality rate and the other prognostic factors, this pneumonia with COVID pneumonia is divided as type ABC. And what we deal usually as endocrinologists is pneumonia with comorbidities. That's diabetes, hypertension, heart disease, or kidney disease. So in these patients, we need to really look at the age, the smoking factor, maybe the male sex, which is important because because of the androgenic effect of the ACE2 inhibitor and the TMPRSS2, that receptors where more there is a more comorbidity, there is a more mortality and morbidity in COVID. So these are those important things that needs to be looked into. And also that the A1C as well as the daily routine care points and the SMBG that needs to be done. The targets are to be kept less than 180. There is one paper which clearly says that 180 milligram or above is a risk factor. But however, if the patient has come into critical care or got admitted with severe and then went to critical phase, then they would try to be a little more stricter in such patients. So these are those important places where we need to actually be very, very careful in for the mortality risk. And then once these are addressed with, as I said, I was talking when you were muted, that we really don't know about this disease, why even 100 years old comes out of ventilator. So we are yet to know. And I think regarding this, if anybody else has to add any other factor, please open to all.
What I was talking about, and Vagish agreed with that. I had an 83-year-old patient of mine come in today. I mean, the patient didn't come in, but the relation came and told me that the patient, again, the same 14 days COVID, and he was hypo. He was 83 and he's come out very well. And all of a sudden, he was taking gliclazide metformin combination. And now his blood sugars are 250, 350, you know, like going up. So he said, the patient insisted, no, I want to go back to the same tablet that I had prescribed. So I think thinking about that, you realize, well, that's the way it works. And the advantage of, and then his blood sugar did come down significantly with even one tablet of gliclazide metformin, which he insisted on having. Yeah.
Right.
Thank you, ma'am. Thank you, Altma sir. So we have some few questions that has come from the audience. So there's this question they have, one doctor has asked from Amritsar. If the blood glucose is under control, can we use SGLT2 inhibitors in COVID patients?
And the SGLT2s are a no-no. I've already said, because of the chances of dehydration, fluid volume loss, the SGLT2s are a no-no. Even post-discharge, for a couple of weeks, they're a no-no. So not SGLT2 inhibitors. Though I told you about this one particular study, which is ongoing. It's phase 3, the DARE study, in which they are using specifically dapagliflozin in patients with respiratory failure. That is the only ongoing trial as of now that I'm aware of. Yeah.
Thank you, ma'am. Altma sir, do you have anything to add to that?
Yes. So I think a little, maybe extension, not addition exactly. In some patients who were kind of mild COVID, we have continued the same regimen, whatever the patient was on the SGLT2 inhibitor dose. And we've monitored these patients with a proper, whether it was interleukin 6, whether it was D-dimer, whether it was CRP. And when they have not really fallen off, or when they have not got a hypoxia, I think they really managed well with the same regimen. However, the patients were informed that we may need to start you on insulin anytime, and they've agreed. So there has been some, I think maybe this was the basis of their trial, but we agree completely with madam that in certain patients, we actually need to go back to the regimen, which may not include this. But however, there is still some more papers coming which talk about not only SGLT2, some special type of monoclonal antibodies to be given to avoid critical illness, to avoid the severe illness. But however, it's very early in time to say, unless that result of that particular trial comes out, and then, because initially when steroids came, everybody will agree with me. So all the four panelists will agree with me. When initially when people were saying give steroids, most of the doctors across the world said, no, how can you give this steroid? It will catch infections. But once it was proven by the recovery trial that yes, DEXA is helpful, like that, I think we need to really wait for time. So we don't know. Science has changed. A lot of drugs have just come and gone, and some have, which were not expected, have stayed. So like that, in mild cases, this is center from, this is experience from this center from Western side. I think others can also add regarding SGLT2. I request Dr. Shriram, Dr. Sam.
Yeah, I think as Madam has told, we should try to avoid SGLT2 only in asymptomatic COVID positive patients.
Yeah, that may be doable.
That we can continue. Otherwise, we should avoid that.
Yeah, but we should make sure that all the other medications are also being continued.
Yeah.
Because quite often the patient has already discontinued the antihypertensive, the dyslipidemic, I mean, everything. So we should make sure that for the overall health of the patient and to avoid the aggravation of the comorbidities, they must continue the routine medication. They must continue that. They're focusing more on the vitamin C and the zinc and the, all the other stuff, but they're not looking into the component of the pharmacotherapy. Yeah.
Right.
Thank you, ma'am. Thank you, sir. Just one more question is there. That is, we have talked about guidelines of for type 2 diabetes patient affected with, but what about gestational diabetes mellitus? For patients in those type of patients, how do we manage, or are there any guidelines?
Talking about gestational diabetes and COVID, only insulin, and everybody will agree with me. I think there is no second this thing. In these patients, insulin is the answer. Yeah, I would say COVID and gestational, please do not even think about metformin in this scenario. And I think all four of us are smiling and agreeing. Yeah. So, Madam is our leader, and Madam, we leave it to you whether you want to continue or shall we wind up? It's going to be 7.
Yes, absolutely. 6:59. We have a minute to go. See, I think with gestational diabetes, the diagnosis, of course, becomes important, because how many tests will you do? How will you do them? You want to have the least possible exposure. So there are a lot of things to be considered in patients with gestational diabetes. Okay, and of course, I agree with you that if you require treatment, then it has to be insulin. If the lifestyle does not work, but the exposure part has to be avoided. So the least number of tests, if you can manage with 1 blood glucose and an A1C, or 2, the least possible. And patients who have already had gestational diabetes in the earlier pregnancy, who know how to do blood glucose monitoring, self-monitoring of blood glucose, I think that helps a lot. That really helps. But exposure should be minimized, and this is the time to do so. The role of telemedicine comes in here in a big way.
Absolutely, yes.
Yeah.
So, ma'am, as you just mentioned about the telemedicine, just one question from my end. So we are aware about, like in this particular scenario, in this pandemic, there are many doctors who are doing telemedicine for many of the patients. So in case of type 2 diabetes mellitus or type 1 diabetes mellitus, how do you see telemedicine for these type of patient profile? Also, what is your opinion? I mean, I would like to ask each panelist here, what is your opinion about the use of vildagliptin in telemedicine? How can we manage, or how can we say that we can give vildagliptin or prescribe vildagliptin via telemedicine?
So gliptins are okay. Yes, madam. Yeah, madam wanted to speak.
No, go ahead. I'm sorry.
Okay.
I was wanting to clarify her question actually. Yeah.
So any DPP4 inhibitor, it's essentially an easy peasy drug which can be even started over the phone. Even otherwise, I think to RMOs also, when we talk about in the hospital, this is one medication which can be easily started without having to explain a lot of other requirements like before food, after food, or 2 glasses of water or not, or check your urine, or you may get more urine, or you may get something else, or you may get edema. So this is one class which gives really you a good result, and you got to explain it to the patient just over the phone. And I think telemedicine does allow to use DPP-4 inhibitors. In fact, even SGLT2, all will agree that we have started in this 1 year itself SGLT2 also over the phone. But however, if it is in relation context to COVID, then I think DPP-4 is also one of the very easy ones to start with. And I would request everybody else to please add to the answer if your experiences.
I think those who are doing telemedicine would be able to prescribe almost all agents across, except insulin, of course, unless you have to have an educator to explain that. Amongst the OADs, oral agents, I think all can be prescribed. It will just take a little longer with some agents to explain as to how they need to be prescribed. But her question was, I think, particularly in the context of DPP-4, which Altamash is absolutely right. I don't think there should be any problem in prescribing a DPP-4 inhibitor. But then see, with the telemedicine, with poor internet connectivity, a hearing problem, you might have to have a family member sitting with them trying to explain. So, and poor understanding. So there are a lot of flaws with telemedicine per se, which need to be kept in mind. Otherwise, I wouldn't think twice about prescribing at least a DPP-4 inhibitor.
Yes,
Samrit sir, Vagesh sir.
I think we are doing telemedicine. We are as comfortable as our regular consultation.
Yeah. Now it has become part of our DP4 inhibitor.
Quite safe. DP4 metformin are quite safe to initiate.
In Chennai and in many parts of Tamil Nadu, I don't know what about other places. There is one Siddha medicine approved by the government and in fact advertised by the Tamil Nadu government. That is called Kabasura Kudinir, which is basically a multi-herbal preparation for basically the cough and phlegm. That's what they're giving, and it is over the counter. And I strongly feel, I mean, that has to be mentioned. I can't pass any political comment against or what as allopathic physician, but we need to be very careful. There have been a lot of reports of at least gastritis, severe gastritis, and many of our patients do not reveal all this, especially in telemedicine and other things. They'll say something with you and they'll be overusing. I'm sure there is a big pandemic on one side of COVID, on the other side, and a pandemic of overdose of vitamin D, overdose of zinc, overdose of vitamin C, everything is happening.
That's what I said.
Focusing
more on that.
So any GI discomfort, which is not uncommon with the DPP-4 inhibitors as well as metformin, we need to know whether they are on the other things also.
Yeah, so, zinc is notorious. Zinc is notorious.
I'm sorry, you may not, I don't know how many of you, this preparation which I am discussing is now, it's government approved. If you go to any government hospital, it will be given 3 times a day to all patients, in addition to all the allopathic whatever thing. And it can cause side effects. I mean, we all know that nothing is, no effect, no side effect. I mean, it will cause side effects. And there is serious gastritis and 1 or 2 episodes of liver dysfunction also, fortunately reversible. We need to be careful.
See,
this is a local problem we face here.
We have to thank a lot of our iatrogenic Cushings due to steroids which have been administered in the garb of alternative medicine, isn't it?
Yeah.
Right. Ma'am, sirs, just one last question and then we can conclude this session. So there's this doctor who, I guess she must be from South. She's saying that they have seen a lot of COVID patients, especially who has been newly diagnosed with diabetes, having high HbA1c. She's not mentioned what is the value of HbA1c. So she wants to know, what is your experience, or have you seen or experienced these kind of situations in COVID newly diagnosed with high HbA1c?
So it's the pre-existing diabetes diagnosed during COVID evaluation.
I think we have not been clear at all. We have not done our work today because we have not been able to explain anything with our discussion. We've just been having a little friendly chit chat, it seems. And that's exactly what we've been talking about throughout. And that is what Vagesh very nicely brought out, that there are 2 types. One is stress hyperglycemia and one is established early known hyperglycemia in which the A1C will be increased. So this person at least had diabetes for 3 months, at least, if not more.
A person with a known HbA1c, which is normal before COVID,
Yes.
has stress hyperglycemia during that 2 weeks, returns to normal, or start of hyperglycemia at the time of diagnosis of COVID with a proven glucose earlier, 2 months, 1 year, or whatever is the duration. And then as we move ahead in time, the A1C increases. Then only it will be a COVID-induced hyperglycemia or COVID-induced new onset diabetes, and that is what I think Madam rightly said was NODAC 19.
Yes.
And there is a COVID diet project also going on. So if I may just add, Madam, with your permission, 2 minutes.
Please.
I had a case who had the normal fasting PP HbA1c in January. In March, March end, this doctor got COVID, and that is the time she had come with neck pain. So it turned out to be COVID induced thyroiditis. I'm telling directly the diagnosis because of lack of time.
Yeah.
She was given steroid, but with steroid, her sugars did not rise. And after 2 months, when she was told to do continuous monitoring, the sugars start going 180, 170. And by the end of May, then her HbA1c increased to 7 points. She thought she will do it with lifestyle, which we also agreed it was only 7. She refused to take metformin or any other tablet at that moment. By July and August, her HbA1c was 11.3. So here we have a case where there's a documented HbA1c normal fasting PP, including at the time of admission, diagnosis, and quarantine. So this has to be the thing. And if there is any value which is HbA1c between borderline 5.7 to 6.4 or otherwise, then it was either a pre-diabetes going into COVID or a stress hyperglycemia entering into COVID. And these are definitions given very clearly by the ADA and their documentation. So I think we got to be really careful. And I agree with both Madam and Dr. Vagish who just said that. Thank you so much. Over to Madam.
Thank you. Thank you so much.
So thank you all the panelists. Thank you Sambit sir, Sriram sir, Vagesh sir, Sarita ma'am and Altama sir for, I think we've learned a lot and gained a lot of insights, especially with the present situation that we are in, and also about the understanding of what the guidelines have also talked about gliptins and metformin and the use of conventional insulin. I thank you all for taking your valuable time to be our panelists for this session. I also thank the audience also for their wonderful questions. And I think we can say a bye to all.
And I hope Dr. Amit Bhargav gets well soon.
Yes, yes.
We missed him. We missed him certainly, but it was a pleasure to have you with us. Sambit, Sriram, Vagish, Altamash.
Thank you, ma'am.
A real pleasure. Really enjoyed the interaction. Thank you. Thank you so much.
Thank you.
Thank you, ma'am. Thank you.